looked at this as practice before, one of the things that you know is that it's full of information. It has so much material in it. And so it's going to take a little while to get through it. I want to make sure that we have time to talk about anything that you guys might want to talk about. I want to sit this right here just to remind you, just to stay on mute unless we're having an active engagement for everybody's quality experience, and some other things that really can add to and enhance your participation in any kind of training that you do. I don't know. I spend a lot of time on Zoom these days like you guys, and it's easy to, be doing other things. But if you really want to get a lot of value out of the training, engaging in the training, using the chat, talking to each other, asking questions, letting us know what you're thinking always is a good way to enhance the experience for yourself and for everybody. And here's just the little information about certificate when it comes out and my contact information. Hopefully, Stratton's letting folks come in the waiting room and all that stuff, and all of those things are getting addressed, and you don't need to text me, but you can if you're having any technical issues. Okay? All right, first, before we get here real quick, I want to do my first poll. I'm going to launch it now, and I'm curious to know if there's anybody out there that actually hasn't ever attended a training that includes this particular information. I'm assuming, yep, and I am correct in that most of you have seen this information before, but it's always good to know how many folks in the audience, this is their first time of seeing this information. So pretty much a majority of you, 90% of you are telling me that you have, in fact, had this material before. I am going to end that poll. You don't need to see those results. You trust me, right? And so one of the things that is going to be a little different from maybe if you've done the NDCI trainings for implementation or the tune-ups is that I'm going to specifically talk about what the national best practices indicate, and some of their material, they don't go into detail with a few of these things, or they don't comment on a few of the things that are in the best practice standard. So hopefully, even if you've seen this training, you have you will learn something a little new today. I want to share my next poll. I'm curious to know of these 10 things that make up the best practice standard for substance use disorder treatment, where you want to prioritize time today while we're together. These are the 10, hold on, let me launch it. That would work, Marie. Still learning these features. These are the 10 things. If you were to prioritize your first and second components that you want to focus on, where do you think, or where would your interest lie in spending time?
Marie, it's not allowing me to submit.
You have to scroll all the way down and answer all of them and then hit submit. There's another question. There's 2 questions.
Yeah, so I've got 2 questions. Five more seconds. Okay, sorry if you didn't get in there. So It looks like evidence-based treatments is really the top focus, with a second of continuum of care, which I expected. So that's good. We'll dig right in, because continuum of care is the very first topic. And it's interesting because the national best practice standards really, like, they lump in discussing continuum of care, they lump so much into this particular section. What we know is that continuum of care consists of everything from the highest level of treatment provided to a aftercare and beyond situation, right? So you have a significant array of services that, if you're providing a full continuum of care, needs to exist. And if you've been around for a while, you know that, especially the further out you get from a city or suburban area, the less likely you are to have access to a full continuum of care. And then recovery courts, you guys are like fully funded and rich, right? And so, with recovery courts too, you have the added hurdle, I guess, of identifying how to provide access to a continuum of care with perhaps limited resources. So, all that is, something that, as I visit with other recovery courts across the country, that exists everywhere. It is almost impossible at times, especially in rural areas, to meet this standard fully. However, I do think that there are opportunities for programs to consider the best practice standards and what they can meet in this area. And so, for example, there are a few things that, when the evaluations and studies were being done, that the evaluators found, and that was that a lot of programs, in an effort to, I guess, make it easy, cost effective from a treatment standpoint, etc., they would put everybody in like residential, and then once they're done with residential, they move them into a low intensive outpatient situation. What they found is programs that do that actually have but poor outcomes. There is no gradual step down in that situation. So they specifically identify that as an example of one of the things that may seem like it would work, but that you receive the least effective outcomes. And we know that there are several of reasons why that might exist, and that is because just sticking everybody into one treatment does not really meet the individual's need. When we're talking about placement criteria, our evidence-based practices indicate that a clinical assessment by a clinician needs to be done in order to determine level of care, and not everybody needs the same level of care. So if you are in fact putting people into the same level of care in your program, like to start out in phase 1 or whatever, you're perhaps doing some folks a disservice and not meeting a best practice. Let me stop and say, I'm not trying to sit here and judge you if this is what you're doing. I really want you to know what the best practices are. And if you are doing it, I want to push you a little bit on, ways you might place based on ASAM criteria instead of doing that. But, I also know that you're in the real world and you're trying to do real world stuff, but this is the best practice. One of the other things that they noted about placement and continuum of care is that in these situations, for example, where you might put folks into residential and then, without considering what their level of care need might be from a clinical assessment, they found that there was a high prevalence of negative outcomes. People weren't finishing treatment. They were recidivating, reoffending basically, because they were not really appropriately matched to the level of care. And they found that a lot of this, and this probably doesn't surprise you, a lot of this was happening with their young male participants below the age of 25. You know, they're obstinate and they know it all. And, you know, they're 23-year-olds in a 13-year-old psyche. They're annoying and hard to deal with, and they don't want to do what they're told. And so perhaps it feels like residential is appropriate for them, but what the research tells us is that, in fact, they receive poor outcomes in those situations. Here are examples specifically from the National Drug Court Best Practice Standards of things that they saw that, in looking at the data, were not as effective as placement based on clinical assessment. Going to the same treatment in phase 1, no matter what, and then just automatically changing treatment level based on phase progression, which hopefully everybody's heard by now, unless you're a brand new program, that we separate supervision and phase management from the treatment need. Those are not, they're not mutually exclusive, but they're not exactly the same either. Treatment and clinical need is addressed completely separately from the behavior management of the court. So somebody may be in phase 3, have a relapse event and need some treatment change. You don't necessarily change what phase they're in, you change their treatment engagement. We can talk about that a lot more if you guys want to. I'm going to pause after continuum of care, these continuum of care slides, just to see if you guys want to chat about it. If for some reason you're a program, for whatever reason, that you are doing any of these things, then keep in mind that if your participants fail because they were not placed in a level of care based on clinical assessment and they fail your program, is it their fault? Because their need was not specifically met. And that might be because either, perhaps it's a resource issue on your part. And if it's a resource issue on your part, then, manage them in a way that you understand that perhaps you weren't a good fit for them. And not that they just, failed and you did everything you could. And maybe you did everything you could within your resources. But you hear what I'm saying? If you don't meet their clinical need, then don't punish them for that. In fact, this particular slide right here, NDCI included this exact same slide in all of their presentations. So if you see their stuff, you'll see it because they're making this point as well. Okay, we'll get to in-custody treatment here in a minute. So are there questions, comments? Do you guys want to talk about any of what I just said? Stratton, are there questions in the chat?
There are no questions in the chat currently. Ms. Murray just said, I truly like this. Hardship so often happens when all clients are in one box.
Yeah. So I didn't like push anybody's buttons and they want to say something. Can't believe it.
I had a question.
Yeah.
How would you assess whether it was the program's failure to put them in the correct treatment or if it was the participants' failure to participate in the treatment they were put in?
So if you're one of those programs where you don't do a clinical assessment to determine level of care needed, or so you put everybody in the same thing, and regardless of what a clinical assessment might say, or if you have a participant who is failing treatment and or relapsing and you are not reassessing them to determine appropriate level of care during the process of their stay with your program, And that would also be an indication that they're not receiving the level of care that they need. So there's really two areas. One, are you cookie cuttering it, especially in phase 1? And 2, are you responding to non-recovery, addiction-related, relapse type behavior from a treatment or clinical perspective? And if you're not, then you're also not meeting their need. I mean, truly, there are going to be people who are not going to succeed because they just darn well aren't going to succeed. And a lot of those might be your 23-year-olds because they're hard-headed and they know it all, and they're 12. But it's something for a program to just think about it. Just think about it. Be open to the possibility that you could do something different if you're not doing either of those two, or if you are doing either of those two. Does that make sense?
Yes, it does. Thank you.
Mm-hmm.
Marie, I think you need to keep in mind also that you can make mistakes in the assessment and evaluation.
Absolutely. You absolutely can. One of the things I would say is that's why you need to rely heavily on a really good qualified clinician to do your assessments. Screening is not going to be as effective to determine level of care or to determine eligibility for recovery court, which is why best practices indicate that you need a clinical assessment done before they enter and before you place them. But yeah, I mean, that happens. Please don't hear me saying I need you guys to be perfect. I want you to know what the best practices are, but absolutely that happens. All right, I'm gonna poke at you some more, especially for those of you who do in custody, because that is the next piece. And I know that some of you do this, and so don't throw rotten tomatoes at me, okay? But when you do it, obviously you're not following ACM criteria because you're not assessing for level of placement. Obviously, if they're in custody, the cost effectiveness of your program is significantly reduced. And while they might tell you that they got a lot out of it, and in fact, I'm sure that they did, the research says that they would also get something out of community-based treatment, and that what they're getting in custody is not necessarily any better than what they would receive from you if they were placed in the community. And you guys can comment on that if you want. I know that those of you who have in custody treatment in phase 1 or pre-phase 1 or whatever it is you do, I know you guys know this. So we don't have to talk about it, but we can if you want to.
Can you define for me what you consider in custody treatment?
In custody treatment is when you have folks who are in jail and they received treatment. They received treatment in jail prior to coming out into the community to finish completion of your program. So I do think there's a distinction between are they in jail and they can't come out and so they're receiving treatment, or are they staying in jail to receive your phase 1 treatment and then they're coming out?
Okay, so
do you know what I'm saying?
Yeah, I was going to say, it says here that it reduced cost effectiveness by as much as 45%, but what if they are not coming out of jail? It's not a condition of their release or parole, but they do need treatment. How do you feel about that?
I think there is an argument to be made that if they are there anyway, and they're not staying in jail because of you,
right.
that is a distinction that is appropriate to make.
Okay.
Okay. All right, this one is really easy, so I'm not going to spend a lot of time on this. Basically, treatment needs to be on your team. There needs to be good communication. Research says that if you only have a couple of them hanging around and being a part of the team, that is better, which makes sense because, you get more folks in a room and it's harder to manage, right? That's just people. So all of that makes sense. I have also been to programs. Golden, Colorado is a great example. They had 5 providers on their team and it worked. They did a really great job. Everybody was invested and engaged, and they had great communication. And so, it is what it is. In the long run, what you want to make sure is that you are providing a continuum of care for your participants, right? So if that means that you end up having to deal with more than one or two providers, then that's what you do. And you work on having clear and consistent communication to manage progress of participants. But this one's a pretty simple, I think, and I don't know that we need to spend a whole lot of time on that. The dosage and duration is one of the things I think where recovery courts are most successful. I'm not telling you anything you don't already know, that you've got them for a long time. And so you have this opportunity that exists almost nowhere else for you to impact the life of somebody who needs services, right? So dosage and duration are really about, how much do they get and how long do you have them? And your typical recovery court, 2 years-ish, if they are if they are high risk, high need, and they're receiving clinical services from you, are going to get about 200 hours of clinically related services. If you think about it, IOP is, over 9 to 12, usually I think around 12 hours a week, and that may or may not include individual therapy. And if you do that for several months, it starts to add up. And then you add the cognitive behavioral components where we address criminal thinking and criminal behaviors in a recovery court, and that adds to the duration of treatment services that you can provide as recovery court folks. And all of these things are a part of best practice standards. One of the things I actually didn't know is when I was reviewing the best practice standards, and one of the things the NDCI doesn't talk about necessarily in their training is that the evidence says that individual sessions during phase 1 with a clinician during phase 1, improves retention and improves treatment outcomes. The other thing that I think is a little contentious is and it's because of resources, I know this, is the groups. Do we stick everybody in group? Do we stick everybody in a group that's too big? Do we stick everybody in a group that's too big with only one clinician? We need to make sure that we do consider when we're looking at how to treat somebody, not just the placement, but what it is that they're receiving and how they're receiving it. Some folks just are not ready to go to group yet. And if you have large groups that are unwieldy, Lord, I've done that. It's hard. People don't get attention. You don't give enough attention. There's the discussion. I mean, it's just hard, which is why research tells us, even treatment research, past recovery court specific research, we know that studies tell us that 8 to 12 is a good, nice groupie number, and that you get better results with 2 facilitators. One which can be a clinician with a license or some kind of credential, and the other that can be a newer person that can kind of back up facilitation and help with group norms. And of course, evidence-based practices within group, whatever those might be. Cognitive behavioral modalities, 12-step facilitation therapy, etc. Whatever those are, need to be in place as well. So this was your second or your first piece that you really wanted to focus some time on. And so if the slides don't get at where you want to go, I'll pause and we can have some conversation about this, because there's a lot of evidence on treating folks in the justice system using cognitive and cognitive behavioral interventions. You know, your standard treatment may not do this, but we're not treating standard treatment kind of people in the criminal justice system, right? And we know this. So we have a lot of evidence that says you need to be using these approaches. You need to be using evidence-based approaches that are manualized, that there is a methodology to. You need to train your facilitators to conduct these evidence-based treatments, and you need to maintain fidelity. If you send somebody to training and they come back and they don't do anything that they were taught, then you're actually not providing an evidence-based treatment. If you send somebody to training and then you have staff turnover and they're just sort of, you know, doing it in front of your new staff, and your new staff don't ever get trained, and you're not really following an evidence-based treatment because your facilitators need to be trained in order and supervised in order to maintain fidelity to the treatment model as it is instructed, I guess is the right word for that. And these are not new things either. And this is a small list. Unfortunately, the registry that we're used to seeing is still not up yet. At least when I looked at it, I looked for it last week and I don't see the national registry up. And I don't know if that's going to happen or not. But right now we don't have that registry that you can look through, which is even indicated in the national best practice standards. It doesn't exist right now. You can't go and do any kind of search for these, but probably everybody who has been doing this work for a little while is familiar with the 4 listed, and they're not the only ones. You can do some research and identify additional ones for sure. But if you're not including cognitive behavioral treatments in your recovery court, I ask that you do that. You're going to address the component of treatment that is around the criminal behavior and the criminal thinking, which is why your participants are in the justice system. And, you know, a lot of people that go to treatment and stay clean and sober don't ever enter the justice system. Your folks are unique in that way. And I know that you guys know that. So I'm going to stop here and see if there's anything in the chat to respond to or any questions.
There is one question. Can we have the PowerPoint emailed to us?
Oh yeah, yes. Yes, absolutely. No more? Okay. Moving on. I'm not going to spend a lot of time here either, because TARCP has included a lot about medication-assisted treatment in our trainings. We've done extra trainings, we've done trainings and panels and everything at the conferences. If you are wanting to have a conversation about this particular component, we could spend a lot of time, and I'm happy to talk with you about this, and I'm happy to send you to people who talk about this. But, you know, here it is. It's, you know, it is part of a best practice that, you know, if you're going to treat folks, that you need to meet them where they are. And sometimes where they are is maybe not where you'd like them to be, but that is still where they are, no matter how much you want them to be somewhere else. And the truth is, you know, we need them to stay alive so that they can get better. And there are people that just need medication to stay alive so that they can get better. And that's the bottom line in my mind. I'm going to move on because we could get into a very long conversation about that, right? Okay, so there are providers on this. There are providers on this training, and I'm very aware. And any provider worth their salt is okay to talk to you about the credentialing of their staff, and about the services that they provide and how they provide them. So as a recovery court, it's one of the things that you need to do is you need to assess, evaluate, ask your providers these kinds of questions. For you as a new program or as a program who is building relationships perhaps with new providers, it's important to build trust with the providers that serve on your team. And a way for you to be responsible for your own trust piece is to find out about the providers that you're looking at. And this is one of the ways to do that, is to get their information about who exactly is in group, who exactly is or would be in group with your participants. Who are the licensed or credentialed staff that are going to be interacting with your folks? You know, your licensed and credentialed people, because they are licensed and credentialed, they are more effective experts in their area than somebody who is not yet. And that's, I mean, you know, our studies let us know that when you become a recovery court judge, you actually, it takes about a couple years before your outcomes get better, you know, because you get better at your job by doing your job. That's just the way it goes. So, you know, it's one of the reasons we ask for licensed and credentialed staff, because they do have a level of expertise from their education and experience that a person who doesn't have that isn't going to have yet. You don't have to have, you can have services that include folks that aren't licensed or credentialed. Absolutely. In fact, the next piece is peer support. So we're going to talk about that a little bit, but your groups, your session, your individual sessions, your clinical assessments, all of those are going to be enhanced in terms of treatment effectiveness, identification of appropriate services, et cetera, with licensed and credentialed staff. So you need to be asking your treatment providers on the team about that. And here are a number of things identified in the national best practice standards. You know, when the person or people providing the services have education that's relevant to the field, they have experience. This is a big one for us, right? Have experience with or have supervised folks working with criminal justice, because our people are different. It's one of the things I love about them, that they are more likely to utilize and be open to evidence-based treatments. When, you know, research comes out and it says this is a better way to do it, they are more motivated and likely to do that. And of course, regular supervision and regular training need to be a part of any treatment provider policies and procedures. So whoever the folks are from a treatment provider that are on your team, you want to know that they are getting supervision from somebody with more experience than them so that they can get better at their jobs, thus doing better at treatment with your people. And they need to be receiving regular training, just like really all the disciplines on the team, right? We're talking about substance use disorder treatment here, but that's something we all should be doing. So treatment people, I'm not trying to pick on you. I come from treatment, that's my background. So those are my people that we're talking about. But these are the things that actually we could spend a lot of time talking about, the things to look at for a provider. If you're a new program and that's one of the things that you are trying to figure out is, you know, is the provider that wants to be my partner or partner in this endeavor, you know, a quality partner? And what is it that we need to ask of them? Other things that I would add to that is that your, especially for those new teams, but even for ongoing, your treatment provider would probably love for you to ask them to provide in-services about the work that they do, the evidence-based modalities that they used and what those are about, how they might be conducted. about any number of treatment relevant things. Those are all great opportunities, not only to meet best practice, but to garner trust among your folks. One of the things that I see a lot in the national work that I've done is that if there's a team that's having a hard time, a lot of times the rest of the team does not trust the treatment provider on the team. And so then what happens is there's this triangulation that occurs because the team doesn't trust the provider. And so the participants start coming to these other team members and whittling away at the team cohesiveness because they've been able to identify that there is a lack of trust between the court and the treatment. And that has to be nipped in the bud. You're going to have a mess if you let that go on too long. So either that requires some come to Jesus meetings with the team, as I like to say, or a review of the treatment provider that you're using and whether you need to switch them out. Anybody have any questions about this one? Questions or comments? Excellent. Okay. So peer support. One of the things that we know is that peer support works, right? We've spent a lot of time and effort in the state of Tennessee to enhance peer support access, right? To hire peer support and to include peer support in our recovery court programs. And there are a number of programs on this this session right now who have peers that are part of the team or at least part of services in their programs. And it would be great to hear some of that in terms of feedback. But we know that peer support in the form of self-help groups, community-based self-help groups actually help with long-term outcomes. And interestingly enough, mandated attendance doesn't mean that it's going to be bad. The evidence suggests that even when you mandate attendance, that they can have some benefit from attending peer support or self-help groups, interestingly enough. Attending those groups isn't in and of itself what really makes it work, though. Really what makes it work are the things that occur while they are attending, or the things that occur to help them get the most out of participating in self-help or peer support groups. And that includes, you know, just being around for a while. I was thinking about this when I was putting the PowerPoint together. I have a family member who just had a year clean and sober. He was addicted to opioids and used the needle and everything. And he has 1 year, and it's probably his third or fourth treatment event that he's gone through. And he's not had that kind of time clean and sober for a really long time. And every time he went to treatment in the past, he went to 12-step meetings, but he didn't feel comfortable in 12-step meetings for a number of reasons. And you know, it's interesting because he goes multiple times a day now. And part of that is about, you know, exposure, right? Long-term exposure. He knew where they were. He knew what they were about. And of course, that maintained connection when he was in treatment, they reconnected him with and talked with him through some of the, I guess, concerns that he had from his perspective about them, and he loves them now. But, you know, I would say that, you know, he's got a year because he's been going to those meetings on a very daily basis. So they're very effective, and which is why we include them, right? But the other things to note that recovery courts can do something about is to use your motivational intervention skills to talk about, you know, what they get out of them, what they say, who they talk to. Are they sitting, you know, are they sitting like a little lump in the corner, or are they talking to people? Are they meeting people? You can also do what they call intensive referrals, which is basically a lot of what the Lifeline and Navigator programs in the state of Tennessee are about. And that is, you know, like a warm handoff in many ways for a peer to be able to show them the ropes. Don't just like give them a list and say, here are where the meetings are, I want you to go to some, but have that person that can, you know, take them, can sit next to them and talk about it afterwards. You know, those kinds of things increase the engagement of self-help and peer support, and ultimately improve the outcomes for somebody to stay clean and sober. And then treatment can also do an evidence-based model that's called 12-step facilitation therapy. Of the programs on the call, does anybody do that? You guys do? I'm not talking about a group where you talk about the step work. 12-step facilitation therapy is an actual model that is an evidence-based treatment modality. Does anybody here do that? Not hearing anybody, so either there's
Hey.
nods because I can't see your faces.
Can you hear me?
Yes, I can.
Okay. Hey, everybody. I'm Debbie, DC4. Is there a manual? Is there a
Oh,
book?
hi,
Hey, how do you, where's the text? Where's the manual? I've never heard of it. I'm
Yeah.
sorry.
So I will definitely include in the information I send out after the after this information about that. Because I think it's one of the rubs with particularly the abstinence-based treatment providers, you know, wanting to maintain that level of commitment to working on 12-step work. But 12-step facilitation therapy is a way to motivate engagement, to talk through and practice engagement with community-based support, so that folks can, you know, have some active practice and discussion and planning around 12-step engagement after they complete. So I'll make sure to include some information specifically about that in the material I send. Okay? If you are, particularly if that's an area where you focus as a provider, having that, being able to say you use that evidence-based model, I think is a really good thing. Anybody else want to comment on any of that? Okay.
Marie, I was just going to say something. Can you hear me?
I can.
I just absolutely love our peer support on the team. We've got a male and we've got a female. And I'm telling you, at times where the team was just at all, didn't know what to do, maybe stuck, it was the peer support that worked, sometimes one-on-one with our participants. And I just can't say enough good things about peer support.
Thank you. Is that Kate?
It is.
Hi, Kate.
Hi.
Yeah, absolutely. I think, you know, I think this dovetails really nicely into the next slide too, because it's about continuing care. And, you know, there's been some focus with recovery courts over the last few years about, you know, how do we, you know, they're gone, right? How do we support them or best support them after the apron strings are cut? Because you're not their parents. You can't keep them. I mean, they can come back and visit, but they've gone to college, people. They're, you know, they've moved on and they're going to do what they're going to do. So how do you, you know, release them knowing that you did the best you could to help them help themselves? And I think peers are a great example of that because they begin to integrate in their communities when you have peers that are in the recovery community in your area, right? So I think they're terrific too. Okay. So what we know, just to reiterate that, is that it's a vulnerable time. We know from doing recovery court that sometimes it's in the last phase when folks start doing crazy stuff, right? And we know why they're doing crazy stuff. Why are they doing crazy stuff? Somebody want to answer? Why are they relapsing or acting out in the last phase?
They're just afraid, fear, I think, of change.
Absolutely. Yeah, it's like, okay, yeah, I'm about to lose the comfort and safety of the situation. And when I was doing this without this before, I didn't fare very well. So I remember what that was like to be me without this, and it's terrifying. And maybe I'm not going to be able to do it. There's absolutely a lot of fear. So, there's a vulnerable time once they have completed your program for the folks in your program, and it's a time for us to think about, what we could do. And these are the best practice ways to provide continuing care to the best of your ability. And that's going to be things like formalizing a focus on relapse prevention and aftercare planning. I don't know how many folks of you have an actual manualized evidence-based model that you use to go through for relapse prevention with your participants. Anybody?
In the past, I've used the matrix model to address those kind of needs. In the prison system, we had whenever we had somebody relapse, we would have them go through the matrix model to get them back on track.
Okay. Anybody else have a relapse prevention component in program?
Yes, we do. A relapse track.
And do you put them in there once they relapse, or they get relapse prevention prior to that?
It just depends, but since COVID, we would actually pull our people back in. We were fortunate we could do that because we were residential, but it's a little different now what we do.
Yeah.
We're using some other kind of ways and means.
We utilize CCI, who does the MRT curriculum, also has a relapse prevention curriculum, and that's what we use in the 25th in Hardeman County.
Is this Ryan?
Yes.
Hi, Ryan.
Hello.
We use the new direction curriculum from Hazelden, and we do it when they're in their last phase before graduation.
How long is that one?
We do it for their last 4 months, just about.
Yeah. Okay. Yeah, so a formalized way to kind of talk about what that looks like, because the truth is, relapse is highly likely. And do they have the necessary tools to get back on track if in fact that happens to them? Aftercare planning, what is it exactly that they're going to do with themselves? It's like, the night you graduate from high school, right? Throw up your cap and everybody goes crazy. Some of them do that. This. Some of them do that. And even if they do, do they have the tools to get back, in the game once they've realized that extra little party they had graduating high school didn't fare so well and is getting them back in the direction that they were going when you intervened, right? So kind of talking through, even practicing opportunities to address relapse triggers. do the folks that they were hanging around with, do they know that they're getting out? Where are they in these folks' lives? You know, are you keeping track of and talking about, you know, who they used to hang with, and are those folks still around? Are they part of their family? You know, if they are for some reason still around, and that's just something that this participant has to deal with, you know, rehearsing and talking through and planning through triggering opportunities is very useful. And if there's a way for 3 months past program completion to have a regular kind of connection, I think this is where 10 Together app can be really great. I don't know how many of you guys are using the 10 Together app, but you know, it's got that social media component where, you know, other folks that have graduated from recovery courts can be there to support them. And of course, you can do some check-ins with them to, you know, just see how they're doing. You could use that kind of a process, Reconnect or something like that, or 10 Together in a formalized way to just continue to check in with them and find out if they're using any of the stuff that you work through in aftercare planning and relapse prevention, using those tools without it having to be super lengthy for you. And of course, alumni groups, we could probably talk a lot about alumni groups. I know some programs have a lot of good results with alumni groups, and sometimes it's really hard. Does anybody have a really strong, thriving alumni group here on this in this presentation?
I do.
With whom are we speaking?
Tawanda.
Yeah.
My people don't leave.
Recovery court?
Huh?
Recovery court people?
All my people, recovery court, treatment centers, drug court, the ones that come out of prison, they stay in the group as alumni.
Yeah.
I got been 7 years. So.
You know, it's interesting because sometimes what I see with alumni groups is that there is those 1 or 2 champions that are able to really, they're connector type people, and they're able to motivate folks to come back in a way that not everybody has access to. I don't know, you know, it's just a really interesting thing, but alumni groups can be extremely effective for that very reason, to stay connected if they do fall off the rails, somewhere to come back to that's safe, and, you know, they know the folks, because, you know, that's what we want for them. We want them to know that, you know, if something happens and they need support again, you know, do it early before you cop another charge. You know, get here. I know you guys tell them this, so I'm preaching to the choir, but these are the kinds of things that you can provide in continuing care. Does anybody have any questions or comments about the continuing care piece? Because I know it's often on the minds of the program staff that I talk to, and can be a source of frustration, right? Anybody want to comment? No?
Marie, something I found out to be beneficial too is like you could expand it into alumni. I have several different ones that go to several different groups, and sometimes they venture into, like, they might spend a day out at another meeting and they get familiar with each other. And so if they see somebody in the other one that's having some problems, they're able to reach out to the other one. So that effect works a lot.
Yeah, absolutely. Makes sense. Okay, so all of this information came directly from the National Best Practice Standards. I mean, the material that I send you, you'll see each of the sections I've got in the notes list, so that you have the notes that are specifically related to that component in the section with the slide that I made. So, you know, if you haven't ever combed through that stuff, you can actually look at this material and look specifically at the information related to that component. Just to let you know, March, we have our conference. So, you know, we're not having one of these, but in April, we have a judge who will be sponsored by the National Drug Court Institute that will do roles and responsibilities. I think they are negotiating contract with her now. I will be back in May with you to do incentive sanctions and therapeutic adjustments. And then they do have somebody identified for equity and inclusion in June. They just haven't, he's not signed his contract yet. And so they've asked that I not release that information. And of course, if you haven't already looked, heard, seen, we have a number of folks. Paul Carey is going to be doing the drug testing one later. Actually, let me get out of here real quick. And I think I have the, yeah, here it is. I'll share this real quick with you. So Paul Carey is doing the one in August, and we have another NDCI sponsored person doing multidisciplinary teams. We have NDCI doing census and caseloads, and Dr. Shannon Carey is going to be doing the monitoring and evaluation one in December. So we have some great folks outside of me. If you're tired of listening to me talk, we have some great folks that are going to be coming and doing these lunchtime learning sessions. We have no more minutes, but I will stick around if you have any questions or you want to talk through anything that we have talked about today. I appreciate you very much, especially seeing my treatment providers on here. I was speaking to the choir today. They could definitely do this for me, hands down. I appreciate each and every one of you and the work that you do with our folks, and just know that. I look forward to seeing all of you in March. So stick around if you have any questions. Otherwise, you are free to go. Thank you.
Thank you. Thank you. It's good to see you. Look good on camera.
Too. Thank you. I don't see your face. There you are. You're in the middle. Everybody's leaving, so you keep moving around. Hi, Jane. You don't have to respond. I just want you to know I see your face.
Thanks, Marie.
Absolutely. I don't know who that was, but you're welcome. Thanks for coming.
That was Scott.